Prior to admission, patient noted sudden onset of dizziness upon standing up from sitting position, associated with 2 episodes of vomiting of previously ingested food. No fever, cough, dyspnea, chest pain, nor slurring of speech and motor deficits noted. Due to persistence of dizziness, family decided to seek for admission. For the past medical history, patient is hypertensive and diagnosed with BPH grade 1, maintained on losartan plus amlodipine and dutasteride and tamsulosin, 1 tampon a day. Patient has no known allergies. Patient is a 5 years older, stopped 25 years ago, non-alcoholic beverage drinker, and has no illicit drug use. For the family history, noted hypertension on both sides. Symptoms, patient came in due to dizziness associated with vomiting. No body malaise, anorexia, no orthopnea, no chest pain, nor seizure. For the physical examination, patient ER awake, alert, conscious, coherent, with stable vital signs, BP of 140/70, heart rate of 60, RR of 19 cycles per minute, a febrile that has no noted desaturation. HENP, no noted neck vein distension, P, febrile conjunctiva, equal chest expansion, has a clear of sound, noted for cardiovascular system, distinct heart sound and has regular rhythm, and no edema. So for the PE, patient was awake, conscious, coherent, oriented in time and person. For the cranial nerve number 1, it was not tested. For cranial nerves 2, 3, 4, and 5, noted isophoric pupils, 3 and both sides. Both are reactive to light and accommodation, no noted ptosis, and has intact extraocular movement. Also, there is no noted nystagmus. For cranial nerve number 5, able to clench teeth and move jaw side to side, and able to identify light touch on forehead, cheek, mandibular area, and has positive corneal reflex. Pertinent for neuro exam is cranial nerve number 7, noted flattening of the nasolabial fold to the left side. Patient is able to hear spoken words, has intact gag reflex, able to turn head both sides against resistance, and tongue has no movement articulations and seen at midline. So for the other physical examination, no noted dysmetria, no nor dysdiadochokinesia, intact sensory system, 5/5 on all extremities, and +2 reflexes on all parts. Did you do Romberg test? Yes, Doc. It was intact, Doc. Romberg is for proprioception. It was no drifting of extremities, no. Amlodipine and losartan, no. No alpha blocker. The BPH, the last ultrasound done was last December 2022. It was grade 1. No urinary symptoms also. Patient has no usual BP monitoring, only the barangay doc, and also every 3 months with his family medicine dito sa Elahang area doc. I failed to ask doc, but sorry doc. 140/70 doc. No attack siya doc. Okay? Wala ko ka-check sa akin. For cerebellar doc, per test for cerebellar system doc is nose, finger to nose test, rapid alternating test, heel to shin, and also gait doc to check for balance or ataxia. I wasn't able to perform the cerebellar doc because when the patient arrived, the patient was so dizzy and still continuously vomiting at the ER doc. I should have done it this morning doc. no nystagmus on EOM, no nystagmus, no torsional rotatory nystagmus nor horizontal nystagmus. Easy siya po. He described it as the environment is ang environment may matuyog do. One test is do the Romberg's test by yes do Polaroid. So we're presented with a 75 years old man, hypertensive, has history of 5 smoker, hypertension on both sides, came in due to dizziness and vomiting. We noted stable vital signs. Noted only on the pertinent and the PE is the neuro with noted nasolabial flattening on the left. So for my working impression, I consider CBD infarct to consider posterior circulation doc with NIHSS1, HCBD not in failure, chronic kidney disease stage 3A. Since this morning I was able to see the previous laboratories, he has increased creatinine as high as 1.4. Secondary to hypertensive nephrospirosis. So I consider CBD infarct to consider posterior circulatory disease is based on the receptor or based on the prior labs doc. He has a December na labs doc. He's 1.4 with EGFR of 40, 48. It's actually the same sa ato current doc. So for my different consider CBD bleed since our patient presented with dizziness and also sometimes CNS lesion presents with dizziness in an elderly. We are presented with a zit and is a 5 smoker and has a non-modifiable risk factor of hypertension on both sides, which can be a risk factor for cerebrovascular disease such as infarct or bleed. Second is I consider CNS lesion because sometimes they present with although it's less likely. Most of the time they present with headache, nausea, or vomiting. Or what do you mean by CNS lesion? Or mga space occupying lesions. No? Probably it's specifying if you want to see it, so because currently the I think it's infarct or I think there is no consider it's something in kind of way, so you can consider the evaluation. Thank you. Probably way to more secure treatment for operator things. Okay, Doc, thank you. So CNS lesion is a kind of chronic sudden onset of dizziness. I think it could also be related to an active symptoms of anxiety or obstruction or venous flow, makakasan ng dizziness. But if patient alone, dili ka siya active to symptoms. Most likely, ang active chronic headache, acute, less like bleed or tumoral bleed. For brain mass sensitivity. So for example, that if I could probably at the cerebellar positional vertigo since on the although this is not a diagnosis, because our patient presented with dizziness, standing man who is a known high na nag-out is sepsis or there is an infection that can cause derangement of mm, or dehydration. Infection, sepsis.
Dehydration is common. About very small consideration.
Or orthostatic hypotension. Aside sa infection, sepsis, dehydration, wala ko nakikita. Ito,
Target to protein. So that should be there. That should be there. It's not there.
okay.
An objective is like that. So you need to check for the to see it's negative.
So ideally, brain should have been done. Upon the arrival of the patient, I suggest that for a CT scan of the brain plane. However, the AP, therefore, cranial MRI, since it was too acute, 2 hours prior to admission. So it was too acute, so basi wala pa yung makita sa CT scan. So we requested for a cranial MRI instead. However, on a Sunday, there is a surcharge mga 4 to 5K, and the family is not amenable to it. Short sila of financial, they just rely on the insurance. So we convinced Doc, but then no good sila Doc. The schedule unta supposedly Doc was the afternoon that day, yesterday, but they refused. So it will be rescheduled today for So for MRI Doc, that is a better imaging for posterior circulation, especially in ischemic strokes, because in CT scan, it poorly visualizes the posterior fossa. With posterior fossa lesion, then there is a dense spectral bone that can degrade the image. So that's why MRI is better than CT scan for posterior circulation. Sorry, no? Um, Sorry lang. Temporal. Temporal. Yes, Doc, it's in the temporal area. Temporals. So an ECG was taken, Doc. Note that upright T wave with increased PR interval of 0.29. The R2R is regularly occurring. However, there is a difference of this part, the R2R interval. This is preliminary as sinus arrhythmia with first degree AV block. So there is no noted ST depression or ST elevation. So other laboratories taken, so remarkable with no noted leukocytes were all within normal limits. Creatinine was noted to be increased at 1.49 with an eGFR of 49. The rest of the laboratories were remarkable. X-ray was also taken, noted trachea at midline with no noted bony deformities. Intact heart is not enlarged and no noted haziness. This is preliminary read as thoracic spondylosis. So for the lipid panel, this morning was unremarkable. So with this still, since we still don't have the more than HDL is not low, is it low though? It should have been more than 40. Also consider nocturnal, currently one has a CKD. Because we want to test the okay. Since I have not ruled out presence of hemorrhage versus infarct, since we have no imaging, I still consider for my revised impression CVD infarct to consider posterior circulation, NIH plus 1, HCVD not in failure, CVD stage 3 is secondary hypertension, nephrosclerosis, and dyslipidemia. So at emergency room, patient was hydrated at 20 drops per minute, put on soft diet with strict aspiration precaution. For the pending labs, still to do cranial MRI, to the echo, 24-hour Holter monitoring was already started yesterday. June is 1 p.m. this afternoon. This is to rule out any present cardiac arrhythmias. This ay, 5 p.m., 4 p.m. pa dahil ito. Pwede siya kasi. 4 p.m. dahil. So, other meds started is betahistine for the dizziness. Since we still consider stroke, the AP started a citicoline. I suggested for statins. However, she waited for the lipid panel. But I suggest ko, Doc, it's for the neuroprotection or the plaque protection of the patient. Let's just wait for the lipid panel, Doc. So, omeprazole was started since patient have, omeprazole was also started for stress ulcer. Patient has BPH, Doc. Ay, nourished, Ay, oh yeah. Yeah, sorry, Doc. Ideally, Doc, for infarct, antiplatelet, aspirin should be started within, especially for mild stroke, start within 48 hours, Doc, with a dose of 160 milligrams to 300 milligrams, Doc. I think wala pang start wala ano pa if it's bleed or infarct. Pero dugay bitaw kayo, Doc, ang MRI. So this morning, patient was seen awake, alert, conscious, coherent, no recurrence of dizziness and vomiting, nor fever, chills, no chest pain, with BP of 120/70, heart rate is 60, RR of 20, active bra with saturation of 98% at room air, with a fluid balance of positive 190. Still noted nasolabial flattening on the left. Patient is clinically stable. To continue meds and to follow up pending labs, especially the cranial MRI. This morning, the patient already able to open his eyes. Yes, Doc. Able to sit up and stand. Wag ko na kung pa stand up. The next time, wala tayo persistent dizziness, try to reassess now the okay, Doc. Especially the hearing overnight. Over the night, I saw the Doc, 120 to 140 over 70 to 90, Doc, average over the night. Thank you, Doc.